All right. Well, it is noon and we want to be thoughtful of your time. So we'll go ahead and get started. Good afternoon. Welcome. I am Jenny Loudon. I'm one of the co-founders of the Alaska Eating Disorders Alliance, and I'm also the current board chair. Today's ECHO is a forum for interdisciplinary healthcare professionals to connect with eating disorders experts and with each other. We will have 2 additional sessions over the next 2 weeks. Each of them will be on Thursday at noon, and we invite you to join us for those as well. In addition, I really want to thank ConocoPhillips for their generous support of this educational program. We really could not have done it without their support. This series has been guided by a hub team of professionals and experts in eating disorders. They will be introducing themselves in the chat box, and you'll also see their bios there as well. Participants who are here with us today can claim 1 credit hour for the session if you are attending live and are here for at least 90% of the session. So you'll just need to complete the evaluation form at the end of the session and follow the instructions on that to download your CEUs. Just a few Zoom reminders. Closed captions are automatically generated, so you can just press that CC button at the bottom of your Zoom screen to access them if needed. Please do turn on your cameras. That's on the lower left button on your screen. And do keep your mic muted when you're not speaking, but feel free to mute and unmute yourself by clicking on that microphone icon on the lower left of the screen. We do encourage questions and comments during this session, so feel free to use the chat box when appropriate, and there will be time also to just join in. And when that happens, please just unmute yourself and share your questions directly with the group. Also, feel free to private chat the session host or myself or any other hub team members if you want your questions asked anonymously. So today, I just want to remind you that the opinions of the hub team and presenters are their own and do not necessarily represent those of AKEDA or any ECHO sponsors. Additionally, this is not a HIPAA compliant space, so we ask that no protected health information will be shared or displayed at any time, and we really want to thank you for all following those guidelines. Finally, we want to acknowledge that we are hosting this session from Anchorage on the unceded lands of the Dena'ina people who have lived on these unceded lands for thousands of years. We thank the Dena'ina people for their stewardship of the lands, the water, the air, and all life that sustains us. We respect the Dena'ina cultural ways and their homelands and shall strive to be good neighbors. And we recognize that in Alaska, there will always be Indigenous land and pledge to work with Indigenous communities with an intent to listen, to learn, and collaborate in a respectful manner. So now on to our program, which we'll begin with a didactic presentation today, and then it will be followed by a case presentation. Today's didactic presenter is Dr. Lisa Weiss. I think I got it wrong. I think it's Dr. Lisa Weiss, an associate professor at the University of Washington School of Medicine. She's a psychiatrist in the Eating Disorders Recovery Program at Seattle Children's Hospital, and she is a board certified in pediatrics, psychiatry, and child and adolescent psychiatry. And she has clinical expertise in eating disorders and medically complex children. She received her medical school training at Washington University and completed her residency at Brown. She has served on the faculty at Duke, Columbia, and Albert Einstein College of Medicine. So with all of that introduction, we'd like to now turn the floor over to you, Dr. Weiss.
Thank you. And yes, I confused you by saying that half the family goes by Weiss and half goes by Weiss, so don't worry. And I have to also excuse the fact that my voice is kind of going away as I am at the tail end of a bout of COVID, so I apologize for that. Let me just share my screen. All right, so thank you for that introduction. And as was said, so I'm Lisa Weiss. I am the medical director of the behavioral health component of the Eating Disorders Recovery Program at Seattle Children's Hospital. Just some disclosures, I will be discussing off-label uses of medications, including olanzapine, mirtazapine, topiramate, naltrexone. I will add the disclosure that even for the medications that are on label for eating disorders, they're only on label for adults, and so all use in children and adolescents is also off-label. And I have no conflicts of interest to disclose for this talk. So we're going to spend about 20 minutes or so on this didactic portion. And my goal, obviously in 20 minutes, I can't cover everything there is to know about eating disorders and medications. But my goal is that by the end, you guys will feel like you have some sense of when a medication may be indicated in these patients. At least be able to identify what is the first line medication for each eating disorder. And then I don't have a lot of time to go into the full details of the side effects of every medication, but my hope is that you'll have some sense of the risk associated with medications as part of that risk benefit consideration when starting medications in these patients. So I'm going to go through each eating disorder separately. We'll start with anorexia. And before I say anything else about anorexia, let me just say that there are no medications that are approved for the treatment of anorexia. And I think this is a really important teaching point, learning point, something to keep in mind always with these patients. Right. We do know that therapy is effective for treating the core symptoms of anorexia. And so that has to be the first line. For children, adolescents, FBT or family-based treatment is your first line. And for adults, it's going to be enhanced cognitive behavior therapy. And so if you take anything away from this talk, I think that that's one point I really want to get across. I'm going to give you an example. This is actually based on a true patient. So a 15-year-old girl with anorexia. Excuse me. She's being managed in the outpatient setting by, getting FBT. She's been gaining weight. She gained weight until about 85% of the target weight that she was working towards, and then she plateaus. She's coming into the office and she's noted to be tearful during appointments. She's making passive suicidal statements like, I can't do this anymore. I wish I was dead. She's not sleeping. She's struggling in school. So imagining this patient, would a medication be indicated? When we're thinking about anorexia, again, we don't have a medication to target the core symptoms of anorexia, but the part of this case that suggests a medication might be worth considering is that plateau, right? She's getting the FBT, she's doing everything she should be doing, but she's not gaining further weight. So in a case like this, we might consider these two medications, olanzapine or fluoxetine, and we'll talk about each of them separately. So olanzapine is often used in anorexia. It is thought generally, and we'll talk about this a little more, but often thought to increase weight gain in these patients and also to decrease the obsessive thinking or distress the patients are experiencing. But when we look further at those two claims, they may not be as wonderful as they sound. This landmark study by Atia and her group that looked at a group of adults they did a randomized controlled trial of adults in outpatient treatment on olanzapine versus placebo, and the olanzapine group gained about 1 additional pound per month. So we are not talking about dramatic increases in weight gain. It does, it's on average. So there are some patients who gain more weight than that and some who didn't gain weight, but on average about 1 pound per month. And so it can be helpful for accelerating weight gain, but it is not going to dramatically change the course of the illness. In Atia's study, they did not find an improvement in the obsessive thinking or eating disorder related thoughts. That is something I still hear quoted. So I was just at a conference last week, and even some of the eating disorder specialists were talking about using olanzapine for that purpose. But I just want to make it clear that in research studies, there's really not evidence to support the idea that olanzapine impacts the thinking. It really is just that it increases weight gain. So there's a lot of medications that increase weight gain. Why? Oh, where did that symbol come from? I don't even know where that came from. Oh, somebody else put that. Okay. So there's a lot of medications that increase appetite, increase weight gain. Why do we pick olanzapine? The thought is that there are these multifactorial ways that olanzapine impacts weight. So the first is increasing hunger. Now we know that's not enough in anorexia because patients with anorexia have an appetite, but they are ignoring those signals. Another piece is that it increases sedation, decreases energy, and therefore reduces the amount of calories that are burned during the day. It also changes metabolism. So olanzapine impacts the way that insulin functions. And in many patients, this increases risk for metabolic syndrome. In patients with anorexia, it may be that it's actually allowing them to hold on to more calories. And then there's also olanzapine has an impact on the reward pathways related to food and eating. And so it's possible that it makes eating more rewarding. But I would say it's the change in metabolism really is where we think the greatest impact is for the patients with eating disorders, and probably why olanzapine is different than other appetite stimulants. So in this hypothetical patient who's actually based on a true patient, we did try olanzapine to see this, right? This isn't going to target the tearfulness, the depressive symptoms, but the idea was to try to encourage that weight gain. And in this patient, she started complaining of cognitive side effects. She started saying, I can't get my thoughts to the front of my mind. I can't express myself. She didn't like how it felt. So it's really important to remember olanzapine has significant side effects. The first two on here, sedation, weight gain, those are what we're kind of hoping for with anorexia. In patients with anorexia, metabolic disorders that hasn't really been found. But probably the treatment limiting side effect is the cognitive slowing, emotional blunting that patients feel when they're on it. There's also risk of movement disorders like dyskinesias, dystonias, akathisia. That's a pretty low risk in olanzapine, but it is there. And then there are some more life-threatening side effects like myocarditis, neutropenia, neuroleptic malignant syndrome. The last one is very rare, but is possible. But in this patient, she really couldn't tolerate olanzapine, and so it was stopped after only about a week. And so then the next question is, would we try fluoxetine in a patient like this? So we know antidepressants are not effective in treating symptoms of anorexia or promoting weight gain, but antidepressants can be used in patients with anorexia when there's a comorbid condition such as depression or anxiety. So there's two truths we have to keep in mind, two things we have to think about. The first is that depressed mood and anxiety, OCD symptoms, these are symptoms of starvation. So we know from the starvation studies done in the past that when people are starving, they start to look depressed and look anxious. And so we want to make sure that we're not trying to treat starvation with an antidepressant, because that is not going to work. But we also know that untreated depression can interfere with recovery from anorexia. So we have to make sure that we're not missing depression in a patient with anorexia. And this can feel really difficult, but there are ways to differentiate them. So for example, in our patient that I described, she has already gained weight, right? So she's gained weight to reach this point, and now she's looking depressed. So I think we can rule out that starvation was the cause of her depression because she wasn't having these symptoms when she was more malnourished. Similarly, if the depressive symptoms started before starvation, before they became malnourished, then it was probably something separate from the anorexia. And so those are the kind of clues you're looking for when you're differentiating these things. Something else to keep in mind is that probably the same mechanism that starvation creates these symptoms, it's changing the function of serotonin in the brain. And so when we give an antidepressant to someone with anorexia, if they are malnourished, we know that just giving them more serotonin is not going to necessarily fix the problem, because there's not just less serotonin in the brain, there's also changes in how the brain responds to serotonin. And so you'll often hear people say that antidepressants don't work when people are malnourished, and that does seem to be true. What we don't know is where is the point where they start working again. I have heard 90% of target weight quoted as the point where they start working again. I don't think it's that straightforward. I think it's okay to try these medications before reaching 90%, but just be aware that they may not work as well when the patient is still malnourished. Also, as an aside, if they're already on an antidepressant and they lose weight and it suddenly seems like the medication's not working, it's not that you just need to increase the dose. It's this problem going on that's interfering with the medication. Antidepressants have side effects. That being said, antidepressants are incredibly well tolerated, and it's just something to keep in mind. I think sometimes we get a little bit anxious about side effects, and the reality is most patients do well on these medications. There is a black box warning about suicidal ideation. Don't have time to go into that now, but it applies to all children, adolescents, and young adults. Something that has to be discussed with families. It's about a 2% increase in suicidal thoughts. So should never be a reason not to use an antidepressant. So going back to our patient, so We do have evidence that she may have a true depressive syndrome going on because it's sort of developing despite or as she's gaining weight. So we try her on fluoxetine, and what happens? Well, like I said, this is based on a true patient, and what actually happened is she got much better. She had significant improvement in her mood, resolution of the suicidal ideation, and then she continued gaining weight and actually eventually became fully restored, weight restored. Sorry. The other thing that happened is she only had to stay on this medication for about 9 months because once she got through that acute phase of the refeeding and all the stress that came with that and sort of settled into a healthier weight, her depression significantly improved and she really didn't need the fluoxetine anymore. So switching gears to bulimia, this one's a hypothetical patient. So, and they're all going to be adolescents because that's the population I work with, but all of this applies to adults as well. So 16-year-old girl with newly diagnosed bulimia. She just started participating in a DBT program for chronic suicidal ideation and cutting. So not necessarily in that DBT program for bulimia, but happens to have both the bulimia and the chronic SI, which is not unusual to see. So would we use a medication in a patient like this? And I didn't give a lot of detail about this patient, but let's talk about medications in bulimia. So we know that SSRIs are effective in treating bulimia. They reduce the frequency of purging. They reduce the risk of depression. Interestingly, I recently read that in a meta-analysis, they did not have an impact on binging episodes, which is interesting because when we get to binge eating disorder, they do reduce binging episodes. So I don't know how true this is, but they do have an impact on the core symptoms of bulimia. That being said, therapy has to be your first line. Medications will never completely treat bulimia. The thought, the idea is that you're going to combine a medication and therapy rather than do either one alone. You can do therapy alone, but I would never do medications alone. There's just a list here on the right of the therapies that are effective for bulimia. DBT or dialectic behavior therapy is on that list. It's a newer area of research looking at DBT for bulimia, but it does seem to have some evidence to support it. So our patient who's already in a DBT program, it might be a good idea for her to stay in that program and potentially add on a medication to treat the bulimia as well, since maybe the DBT isn't entirely focused on her bulimia. Another important point is that SSRIs do help bulimia symptoms even when depression's not present. So that's the difference with anorexia, where you're only going to prescribe an SSRI if they have comorbid depression or anxiety. So fluoxetine specifically is the only SSRI or only a medication period that has FDA approval for the treatment of bulimia, and that is in adults. We do use it in adolescents as well, and it has indication in adolescents for other diagnoses, so we know that it's safe. The other SSRIs probably work fine too. It's just that fluoxetine is the one that got the FDA labeling. This slide is to emphasize the fact that in the studies of fluoxetine for bulimia, it was the higher doses that were effective, so usually around 60 milligrams. And so if a patient is started on 20 and left there, chances are the medication may not be effective, and it's really important to titrate the dose. Just a quick note about topiramate. So topiramate is also effective in treating bulimia symptoms. Topiramate is an anti-epileptic medication, mood stabilizer, shown to decrease the frequency of binge episodes, and it's also associated with weight loss. But that weight loss piece, I think, should be a little bit of an alarm when you're thinking about bulimia, because what can happen with weight loss is that as they start losing weight, they kind of flip into anorexia. And so it's dangerous to use topiramate in a patient with bulimia because of this risk. Bulimia can often a patient can go back and forth from meeting criteria for anorexia versus bulimia, and we don't want to push them. So we really want them to not lose weight, but to simply reduce the binging and purging behavior. The other problem with topiramate is the cognitive side effects. So topiramate is famous for creating problems with memory, word finding difficulties, and so executive functioning problems. And so the cognitive limitations are really the biggest limiting factor in prescribing topiramate. So in this patient, it would probably be most reasonable to try fluoxetine. So imagine she's been started on fluoxetine 20 milligrams daily, still struggling with binging and purging, doesn't think the medication's working. What do we need to do? We need to titrate, right? That's, again, I can't emphasize that enough. People forget to go up on the dose, and you really are targeting 60 milligrams. Just a quick note about naltrexone. Naltrexone, there's really very little research. So naltrexone is an opiate antagonist. And so it's used a lot in the treatment of addiction. And there's been some thought that eating disorders resemble addiction, particularly bulimia. And there are some case reports in open label studies that show some positive responses when bulimia is used, but there's really no randomized controlled trials. And as we'll talk about in binge eating disorders, where there are now some randomized controlled trials, so far they are not showing a lot of improvement with binge purge behaviors. And so there really isn't enough to support using naltrexone. And so if it is used, it's kind of a last resort. It's a medication that doesn't have a ton of risk, but again, not a lot of reward either. So switching into binge eating disorder, example case, 16-year-old boy with ADHD and obesity, wants to lose weight, reporting binge eating, especially in the evenings, no purging or compensatory behaviors. So the only medication with FDA approval for binge eating disorder is lisdexamfetamine, also known as Vyvanse. This is a stimulant originally created for treating ADHD. Lisdexamfetamine is associated with decreased weight, decreased binging, and improved metabolic outcomes in patients with binge eating disorder. Stimulants do have side effects, but they are also very well tolerated in general. Insomnia is probably the most common. Some irritability is sometimes seen. Headaches can occur in about 10%. Stimulants do have the risk for misuse, but I will say that lisdexamfetamine was specifically designed to reduce the risk for misuse. So it's a prodrug, which means it has to be activated in the body. So you can't snort it, or you won't get like a rush like you do with some of the other ones. And so it is kind of the safest medication when it comes to the risk for abuse. So lisdexamfetamine is effective for treating binge eating disorder. Topiramate and SSRIs have also been studied just like they have in bulimia, because there is that overlap between bulimia and binge eating disorder. So we already talked about what lisdexamfetamine does. How does it compare to the others? Topiramate also is associated with decreased binging and weight loss, just like lisdexamfetamine, but it does not show the same benefits for triglycerides, and so it doesn't have the same benefits for the metabolic effects of obesity. SSRIs do decrease binging. Like I said, that was something that was found in these studies, but not in the bulimia studies. But SSRIs also decrease depression, but they're not associated with weight loss. And we talked about how we didn't want weight loss in bulimia. In binge eating disorder, often we do need a little bit of weight loss because a lot of these patients are struggling with obesity. But so SSRIs don't help with the weight loss, but SSRIs are a really good choice if there's comorbid depression. And so you really want to pick your medication based on any comorbidities the patient might have. So what about Contrave? This is a new medication. Contrave is the brand name, and it's a combination of bupropion and naltrexone, and it's been shown to be effective for weight loss in patients with obesity. So Contrave has been studied in patients with binge eating disorder, and it was effective for weight loss, but it did not reduce binge episodes. So it's really not getting at the core of the problem or the emotional distress associated with binge eating disorder. And so it's really not recommended in the treatment of binge eating disorder. The other thing I will point out here is bupropion is contraindicated in patients who engage in purging because it's associated with increased risk of seizures. And since someone with binge eating disorder could shift into bulimia, could shift into purging, generally wouldn't recommend using anything with bupropion in patients with eating disorders in general. So our patient, lisdexamfetamine, makes the most sense because he also has ADHD. So we're going to be able to target both things with one medication. If we imagine he has no significant change, what do we need to do? This is like the last case. We really want to titrate that dose. So again, it's the higher doses of lisdexamfetamine that seem to be most effective. So doses around 60 to 70 milligrams. So it's always important to titrate the dose and not just leave them at the starting dose. I'm not going to spend a huge amount of time on ARFID because it is such a heterogeneous diagnosis and we could talk about it forever. But I will briefly go through the three phenotypes of ARFID. So the first is the fear of choking, fear of vomiting form of ARFID. This is most common in the younger age group. So we see this in like elementary school age kids, young adolescents. This is really a phobia. It's a phobia that leads to an eating disorder, but the core is the phobia, and behavioral therapy is the best treatment for phobias. There are no medications that treat phobias. Sometimes people use benzodiazepines to acutely manage a phobia, like I'm scared of flying, so I'm going to take Valium so I get through this airplane ride. There's really no evidence to support that use in ARFID patients. And you want to be careful. I mean, even in adult patients where like, if you need it for every meal of the day and they're going to eat 3 meals and 2 snacks, you don't want to be taking benzos all day long. It's just not realistic. I'm sorry, my dog is making an appearance. And so really, we don't use benzos. If there is comorbid anxiety, which many of these patients do have, then an SSRI would be appropriate. My slide won't advance. There we go. In the patients with the like chronic low appetite form of ARFID, and this is usually more common in the older adolescents, young adults, you want to first think about like why they have low appetite. Is there some sort of etiology? Are they depressed? Do they actually have anorexia and they're just not being honest or open about why they're restricting their eating? So you want to rule those things out first. If there is depression driving the low appetite, then you want to treat that. If you've ruled everything else out and this patient needs to gain weight, then you can use an appetite stimulant to help them gain weight, such as mirtazapine or olanzapine. We already talked about olanzapine, so really quickly, mirtazapine is an atypical antidepressant. It works on more receptors than your typical SSRI. The main side effect and limiting factor of mirtazapine is it's incredibly sedating, and it does have the sort of antihistamine effects of that dry mouth constipation. Mirtazapine also has the black box warning about suicidal ideation, so that has to be discussed with patients as well. Finally, the last phenotype is the picky eater, seen most commonly in kids with autism, but can be seen in any picky eaters. Behavioral therapy is usually done by occupational therapists, speech therapists, or psychologists. That's going to come first. You want to make sure that you are not overreacting to just somebody who is low weighted, but is going to be low weighted and healthy, and really want to be considering whether you need to intervene with the kid. And if you do need them to gain weight, then again, your appetite stimulants are going to be your first choice. So wrapping up, hopefully I haven't talked too long. How do we want to approach eating disorders? The first is to gain that thorough history. We want to know what are the comorbidities, because that might direct your medication choices. You want to think what came first, the psychiatric symptoms or the malnutrition, because we don't want to treat malnutrition with a medication. And weight restoration for any underweight patient is the first step to recovery. If a patient is struggling with weight restoration, then olanzapine is generally going to be your choice in addition to therapy to help them gain weight. And if they have an eating disorder with an FDA-approved medication to treat that eating disorder, then it's reasonable to try one of those medications. Or if they have a comorbid diagnosis, you can target the comorbidities with the medication. And then last, I will not spend long on this, but try not to use too many drugs. If something doesn't work, stop it. And then in patients with low weight or purging behaviors, watch for QTC prolongation, electrolyte abnormalities. Consider whether they have bradycardia, orthostasis, hypotension, because these medications can exacerbate that, and always check their weight and growth chart at all visits. All right, and that takes me to the end. So I will stop sharing my screen.
Wonderful. Thank you so much, Dr. Weiss. That was a wonderful presentation. I'd like to open the floor now for comments and questions. Remember, there's no such thing as a dumb question, and we really find that this conversation piece is a really great way for not only individuals to learn, but our learning community as a whole. So we really encourage you to ask questions. You may do so by either putting a question into the chat if you'd prefer, or feel free to unmute yourself and ask the question that way if you'd prefer. To get us started, I'll ask a question. So you mentioned the concerns with bulimia and some of the medications that can encourage weight loss. Is there any concern with some of the ones for binge eating disorder that may also lead to weight loss, that those may also kind of push a patient from binge eating disorder into other diagnostic migrations of restrictive or other types of eating disorders?
Yeah, I think that so this is a really interesting question, and I don't think we have enough research on it. Because I think anything that causes weight loss in any person of any size, shape, build is at risk for causing the cognitive changes of starvation, which can develop into anorexia. So there's new research that when people are malnourished, they develop body image problems, that there's an
Mhm.
association. So yes, anything that causes weight loss puts someone at risk. And I would argue that that means that the GLP-1 agonists, the um, bariatric surgery, all of these things have risks. And I don't know if there's been much research done into that at this point. I know there's a lot of talking about it.
Mhm.
And so I think we generally say, oh, someone who has obesity and binge eating disorder, we want them to lose weight, but I'm not sure that's always true. And I do think we have to be really careful about that. But you will hear more of the concern in the bulimia patients because bulimia is often associated with people are more likely to be normal weighted. But even normal weighted, as I say that, right? Like that's that's not a good term, but just it's ingrained.
Thank
Um,
you.
I don't know if you want me to call on people or if you
Yeah,
want.
we can go ahead. Holly, you've got your hand raised. Do you want to unmute and ask your question?
Yeah, first of all, thank you so much. It's really helpful to learn more about medications. I have a 17-year-old, fairly high level athlete who meets criteria for bulimia. And we're doing the supervised eating thing, food is medicine, all of that. They are doing better, keeping the food down, but definitely still purging. And they have extreme social anxiety, especially around people they don't know. I have been trying to talk to this client and the family about medication. They are very adverse to the idea, and there is fear of weight gain. I would say that this person is of normal weight, but they really need help with the purging and with the social anxiety. A lot of irritability. And I would just love to hear your comments on that case.
Yeah, I mean, I think that SSRIs have gotten a reputation for weight gain in the general public, and I would
Mhm.
say that they actually don't have a huge association with that. Now, there are people who gain weight on antidepressants, but that is not the norm. That is not what's expected. This is for your knowledge, though, not for the patient's knowledge. This is not how I would convince them, but just in general, I do not
Great.
find that there is a significant weight effect of most antidepressants, and fluoxetine in particular, I do not find is associated with particular weight gain. Somebody had asked about, I see in the chat about Lexapro or escitalopram. That's the one I find the biggest weight gain with, but I think that it's also anecdotal. So one, their concerns are probably inflated by their eating disorder.
Great.
Two, I think the language, it's just really these patients are going to worry about this kind of thing all the time, and we have to help continue to kind of use things like motivational interviewing to focus on what are the benefits and the benefits outweigh the risk of gaining weight, right? And can we help them see that? Can we externalize the eating disorder and label that thought, I won't take this in case I gain weight, as the eating disorder's thought, and what do you want, trying to do that kind of thing.
Yeah.
Because if they have of all the anxieties, social anxiety responds the best to medicate. Like in the studies, whenever they break down the different types of anxiety, social anxiety drives most of the effect size. And so social anxiety responds very well to antidepressants. So if they can get them on on Prozac or yes, and answer the other question, any SSRI,
Mhm.
then they will probably benefit from it. So
Yeah. I mean, people always talk about the side effects, and I always reframe it and say, well, let's talk about the positive side effects,
Or
right?
what are the side effects
Yeah,
of not doing it, right? Like what are the risks of
exactly.
not taking the medication?
Exactly. But yeah, no, that's helpful. And I feel like the population that I work with is so anti-medication, right? Because it's just for athletes, it's just try harder, right? Like dig in, right? And that's actually the problem that's like what got him in this, place, in the first place. So,
Yeah. I
right.
also emphasize, now this is really more for depression, but I emphasize that the recommended amount of time on an antidepressant is about 1 year.
Hmm.
So a lot of people I think they're going to be on the medications forever, and it's helpful to remind
Right.
patients that they're not going to be on the medication forever.
Hmm.
And so yeah, so it can just thinking of it as like we're just getting you to a healthier place, and then we're going to stop it
Yeah.
because you know um,
Yeah. And I mean, this is outside of my scope, but can you just talk about how soon you titrate up? Like I know it probably depends, but
uh,
I think the therapists we get a lot of questions, and I always preface
uh,
it with like, hey, this is not my it's outside of my scope, but I'm just trying to increase my own knowledge.
so you can titrate as fast as weekly for most, if
Okay.
not all of these medications. Usually with antidepressants, we say 2 weeks because most of the benefits occur in the first 2 weeks. So if you look at the slope of the curve,
Mm.
it starts to level out at about 2 weeks. And so we say where you are, if you've been on this dose for 2 weeks, then where you are at 2 weeks is kind of, you're not going to get much better than this. And so
Mhm.
that's why we give, if you go only give it 1 week, you might be able to safely go up, but you might end up going past the point you need to be at.
Yeah.
And so antidepressants is usually 2 weeks that people will titrate. And for stimulants like lisdexamfetamine, it can be weekly because that effect happens right away.
Okay.
Um, some of
For
it, though,
fluoxetine, oh,
fluoxetine 2 weeks.
do you
Yeah.
go 20, 40, 60, or do you?
Um, Depends on whether it's adults or children. So children and adolescents, we usually go by 10, adults by 20.
Okay.
And I think that all this being said, if it's a pediatrician prescribing or a primary care doctor, it's you can't see a patient every 2 weeks. Like it's
Mhm.
just not realistic. And so for the early titrations, you might say, here's 10 milligrams of fluoxetine, go up to 20 in 2 weeks on your own, right? Because you know they need to go up. For the titrations beyond that, you kind of need to see them to know if they need to go up. And so the rate is limited by how frequently you can see the patient.
Okay.
So I
Thank
see them every 2 weeks when I start a med, but I have fewer patients.
Thank you, everybody. I wish we had more time to talk about questions. This 1 hour format things go quickly. So I just want to thank you again, Dr. Weiss, for being here and for your presentation and for answering questions. If others have questions, feel free to put them in the chat and we will do our best to see if Dr. Weiss can respond to them.